with your
Good
wishes, it should
evening
be
all,
soon, I
and
hope.
welcome to the RSA Academic Webinar Series, which is now being live streamed, and I hand it over to Dr. Vishal Singla, please.
Very good evening, sir. Thank you very much, sir. I hand it over to Madam Dr. Sujata Ghosh, please, ma'am. Please carry on.
A very good evening to my respected seniors, my colleagues, my residents and dear students. I first convey my heartfelt thanks to our President, Sir, Dr. Naveen Malhotra, and our Secretary, Dr. Vishal Singla, and I also pay my respects to Tejkal, Sir. Today we stand at an interesting intersection in perioperative and critical care medicine. We have shifted from chronic disease optimization, and it is meeting with a resource-conscious, outcome-driven approach. Two areas that perfectly embody this evolution are chronic obstructive pulmonary disease and management of patient blood transfusion. But before we embark on this journey, I request our President, Sir, Dr. Naveen Malhotra, and our Secretary, Dr. Vishal Singla, to address you with a few words.
Good evening all. Namaskar. Respected Dr. Tejkal, sir, and our team members from RSA West Bengal. It rewinds the good memories of RSAP Con Kolkata. We had come there in 2023 when Dr. Palash was the scientific secretary. So I'm happy that we are having another academic program by team RSA Kolkata. And thank you, Dr. Sujata, for coordinating it. And no program is successful without the faculty. So I thank Professor Arpita Laha, Professor Mosmin Yogi, Dr. Palash Kumar, and Professor Maitri Mukherjee. Thank you for sparing your valuable time to be here with us in this webinar. And the topics are excellent, pertaining to COPD and blood management. So we look forward to an interactive discussions from all of you. Thank you very much.
Thank you, sir. Dr. Vishal, please.
Good evening, everyone, and my regards to respected President Dr. Naveen Malhotra, sir, our patron Dr. Tejkal, Dr. Sujata Ghosh, madam, and the team. It's a big day in the history of West Bengal because of elections, as well as a long pending webinar has finally concluded. My congratulations to team West Bengal for preparing this webinar. Very apt topics: COPD and evidence-based patient blood management. And I congratulations again to the team West Bengal, and thank you very much. Over to you, Madam Dr. Sujata, please.
Thank you, sir.
Hello. Anji.
Traditionally, COPD was viewed as a progressive, largely. Is there any? Am I audible?
Audible, but echoing is there.
Please
Now,
carry
if
on.
you are on the two devices, please switch off one device.
No, I am not logged in from two devices.
Okay.
I'm logged in from the same.
Dr. Rajib, you are please requested to mute yourself. Dr. Rajib. Madam, please carry on. Dr. Rajib is mute now.
Yeah.
All are muted, so Dr. Speaker can unmute themselves. Sujata, please unmute yourself and go ahead.
Traditionally, COPD was considered as a largely irreversible disease where our role was limited to bronchodilation and oxygen therapy. However, that has shifted dramatically, and modern COPD management is guided by the frameworks of the GOLD criteria, and it is no longer just about airflow limitation. And we have shifted from COPD being a risk factor to a modifiable variable. So now, without any further delay, let us have a short discussion on how this has really shifted. And with us, we have today an eminent panel of speakers. We have Professor Orpita Laha, Professor and HOD, Institute of Medical Education and Research and SSKM Hospital. She has been a postgraduate teacher for the last 20 years. Professor Moushmi Neogi, Professor and HOD, Calcutta National Medical College. She has been teaching postgraduate students for 20 years. Both my experts were speakers in the national platform and have made commendable contribution in our field. Professor Moitri Mukherjee, professor in Malda Medical College. She is a postgraduate teacher with a long experience and a workshop coordinator in RSCP Con, Kolkata. Dr. Polash Kumar is a very familiar figure with us in RSCP. He is a postgraduate teacher and was a scientific secretary in RSA West Bengal and RSCPCon conference in Kolkata. And last but not the least, I am Dr. Sujata Ghosh, professor and HOD, Rampurhat Government Medical College. I have been a PG teacher for the last many years and the joint organizing secretary of RSCP conference, Kolkata. And with this, we go on to our discussion today. My first question goes to Orpita Laha, Madam. Madam, what are the newer concepts? Today, we are not going to go into the anatomy, physiology, biochemistry, pathology of COPD, but we will really talk about the newer concepts. So, Madam, what are the newer concepts in the pre-operative assessment? What do your PGTs being taught nowadays?
Yes. Good evening, everybody. First of all, I want to thank RSA West Bengal branch for giving us this opportunity to talk in this webinar. Now, coming to the main topics, the newer concepts in COPD assessment focus on early detection of treatable traits, number one. Number two is evaluation of the severity of diminished respiratory function by symptom burden, by history of exacerbation, along with by early imaging, and determining the improvement or optimization of the patient's medical condition. According to updated concepts, detection of early or pre-COPD, that is previously known as gold zero criteria, they are actually symptomatic individual, but without any airflow obstruction in spirometry. For them, early intervention prevents progression of the disease. According to Gold 2023-24 criteria, the term young COPD refers to COPD patients within age group of 20 to 50 years. Several studies have shown a greater recovery of FEV1 in younger patients with early intervention. Another term is there, that is PRISM. PRISM means preserved ratio with impaired spirometry. Here the ratio of FEV1 FBC is unaltered, but FEV1 and FBC is decreased. These patients are associated with greater symptomatology, decreased exercise tolerance, and increased admission rate. Advanced CT imaging is also coming in to detect the disease progression before it appears on the spirometry. Another important aspect is blood biomarkers, that is blood eosinophilic count. When eosinophil rate is more than 300 per microliter, it causes increased severity and acute exacerbation of disease, and these patients are very much in potential benefit for inhalation corticosteroid therapy. Then multidimensional assessment like assessment of functional capacity by stair climbing test or 6-minute walk test. Then another thing is genetical profiling by assessment of alpha-1 antitrypsin deficiency. This help to detect the underlying drivers of the disease. Then to determine the severity, several scoring systems depending on some questionnaires have started. One is modified medical research counseling. Please share my slide, first slide, if possible, first slide.
Requesting Moitri, the slide, please.
Yes. According to Modified Medical Research Counseling, MMRC, they use dyspnea score to assess disease progression. Guidelines recommend that MMRC, if it is more than equal to 2, means more severe symptoms and disease. The grade 2 means patients unable to walk in normal pace without having any rest. So COPD assessment, another COPD assessment test, that is CATS test, includes 8 items related to dyspnea. These are all questionnaire based. Apart from dyspnea, other components are cough, sputum production, chest tightness, sleep quality, self-confidence, energy levels. According to GOLD guidelines, patients with CATS score more than equal to 10 and MMRC score more than equal to 2 have prominent symptoms and may need hospitalization. On the contrary, CAT score less than equal to 10 and MMRC less than equal to 2, having these patients will have less symptoms and not leading to hospital admission. In a nutshell, these are the common important recent guidelines for COPD assessment. Thank you.
Microphone, unmute.
Unmute.
Unmute yourself.
My next question is to Moushumi Niyogi Madam. Madam, what are the red flags that you tell your postgraduates during the pre-anesthetic evaluation?
Good evening. Am I audible?
Yes, you are. Please.
Yes,
Thank you, organizing committee, for giving me this opportunity. It is a very important topic for all the postgraduate students. Pre-anesthetic evaluation of chronic obstructive pulmonary disease patients aims to identify those at high risk for post-operative pulmonary complications, such as respiratory failure, pneumonia, and prolonged ventilation. Red flags during pre-anesthetic evaluation of COPD patients include recent acute exacerbation of the disease process. It can be diagnosed by a worsening of symptoms within the last 4 weeks, and it is a major contraindication to elective surgery. There might be reduced functional capacity. It is inability to climb 2 flights of stairs or walk 350 to 400 meters, and productive or chronic cough for more than 5 days pre-surgery is a high risk factor. High risk surgery type like upper abdominal surgery, thoracic surgery, and open abdominal surgery is problem. Signs of infection like fever or purulent sputum, severe airflow obstruction, FEV1 less than 50% predicted, and if there is hypoxemia or hypercapnia, low SpO2 less than 90%, or elevated PaCO2 more than 45 millimeter of mercury is the risk factor.
Unmute.
And I would also like to ask you about prehabilitation. What is the role of prehabilitation in these patients? And how is triple therapy, which is a more recent mode of therapy, helping in this prehabilitation of these patients?
Rehabilitation is important to reduce the post-operative complications. It has been found that with proper prehabilitation, we can reduce the risks up to 30 to 60%. It improves surgical tolerance by enhancing respiratory muscle strength, exercise capacity, and lung function. Prehabilitation helps make previously high risk or borderline patients better candidates for surgery. Faster recovery and shorter hospital stay. Enhanced functional capacity. It includes inspiratory muscle training to improve the strength for the patients. It is a multimodal approach which supports nutritional optimization and psychological supports also. Triple therapy is the combination of an inhaled corticosteroids with long-acting beta-2 agonist and long-acting muscarinic antagonist. It plays a critical role in the prehabilitation of COPD patients, particularly by optimizing lung function and exercise capacity to prepare them for physical training or surgery. It acts as pharmacological bridge that enables patients with severe symptomatic COPD to derive greater benefits from pulmonary rehabilitation.
Thank you. Thank you so much. And a question to Professor Orpita, madam. Madam, are you using inhaled corticosteroids as a routine practice nowadays? And
No.
what are the newer medical interventions that is being used, being taught, and being practiced?
Inhaled corticosteroids cannot be a routine practice because the long-term use of inhalation corticosteroid therapy causes increased risk of pneumonia, osteoporosis, and mycobacterial infection, and so other type of complications. And so the special indications for inhalation corticosteroids are COPD exacerbation cases, severe COPD, that is gold criteria 3, 4, and the COPD associated with high blood eosinophilic count, that is more than 300 per microliter, and the patients having type 2 inflammation processes. But a recent study conducted by Stone et al. Reported that reduction in hyperinflation through effective bronchodilator mediated by inhalation corticosteroid is very beneficial, very effective. The newer medical intervention means the updated gold criteria has reported important changes in pharmacological management of COPD, and it includes optimum use of inhalation corticosteroid, inhalation combination treatment, along with targeted therapy. Evidence support use of targeted therapy against type 2 inflammatory diseases like dupilumab or ensifentrine. According to the concept of precision medicine, 2025 Gold has recommended that combination of 2 to 3 drugs of inhaled bronchodilator with or without inhaled corticosteroid targeting the drug delivery to the lungs, while with minimum systemic exposure. Gold recommended the use of monotherapy with long-acting bronchodilator with long-acting beta-2 agonist or long-acting antimuscarinic agent, LABA or LAMA, indicated with when newly diagnosed cases with CAT score less than equal to 10. These patients are having less symptoms and improved lung function has been detected. But the dual bronchodilator therapy with combination of long-acting beta agonist LABA plus long-acting antimuscarinic agent LAMA in a single inhaler combination provides greater clinical benefit for patients with CAT score more than equal to 10. History of exacerbations and patients with severe symptoms. Now, another important aspect is targeted therapy. These are newer treatment strategies targeting specific inflammatory pathways against interleukin 3, 4, and interleukin 13 and stop inflammation. These are nothing but the antioxidants, phosphodiesterase 4 inhibitors, that is one is roflumilast, protease inhibitor, chemokine inhibitor, endothelin inhibitor like bosentan, VIP, macrolides, etc. These newer treatments targeting specific inflammation are known as biological drugs. Now, stem cell therapy, FDA has approved it in human clinical trials, but currently not available for treatment, to be used to regenerate lung tissue and reverse lung damage. Now, these are the newer medical interventions available now.
We are hearing a lot about biologics
Yes.
and roflumilast. Madam, I believe we do not have it in West Bengal currently, but given a choice, if you had all of this, how would you be using it and what would you prefer to use?
Yes, biologics, patients with asthma COPD overlap condition. One condition is there, ACO, often experiences frequent exacerbation and very poor quality of life. Asthma COPD overlap condition. These patients having increased type 2 inflammatory reaction and are much benefited by biological therapy. These are in anti-inflammatory agent and working against specific inflammatory pathways. I mentioned interleukin 4, 5, interleukin 13, and thymic stromal lymphopoietins, and transform severe asthmatic management and have shown promises in patients with COPD having high eosinophilic count. And roflumilast is the phosphodiesterase 4 inhibitor. It reduces hydrolysis of CMP and causes increased accumulation of COMP in neutrophil eosinophil macrophages and causes decreased inflammatory mediator and decreased neutrophil and eosinophilic count in sputum. Their indications are also same, severe COPD and like gold criteria 3, 4, COPD exacerbation and COPD having a asthmatic trait, that is increased blood eosinophilic count. Daily roflumilast of oral dose 500 microgram tablet in combination with standard bronchodilator therapy with inhalation corticosteroid provides new option for treatment of severe COPD. These are the certain biologics we can use for asthma, but recently they have shown promising result in COPD also with allergic trait. Overlapping eosinophilic and allergic traits of COPD are potentially candidates for this biological therapy. Several trials are going on and further prospective randomized control trial are required to establish their role in the long-term outcome and in these growing subgroups. These are the biological drugs, but these mainly work against specific inflammatory pathways like interleukin 4, 5, interleukin 13, etc. Mostly used by subcutaneous route like dupilumab, mepolizumab, beralizumab. These are all originally approved for asthma and recently having promising result in COPD. Thank you.
Thank you so much, madam. Now I have a question for Moushumi, madam. Madam, what is the biggest paradigm shift in ICU management of these patients? A lot many patients, either due to the surgery or due to exacerbation, are shifted to the ICU. How are you working it differently? Are you using HFNO?
Yes, ma'am. The biggest paradigm shift in the ICU management of patients with COPD is the widespread adoption of non-invasive ventilation as the first line of management for acute hypercapnic respiratory failure, replacing immediate endotracheal intubation. The shift has transformed the management of acute exacerbations by significantly reducing the need for invasive mechanical ventilation, decreasing mortality, reducing the length of ICU stays, and lowering complications such as ventilator-associated pneumonia. Key aspects of this paradigm shift: early initiation of NIV, non-invasive ventilation. It is now recommended as an initial standard of care for patients with respiratory acidosis when pH is less than or equal to 7.35 and PaCO2 is more than or equal to 45 millimeter of mercury. By avoiding intubation and deep sedation, NIV enables faster recovery and better patient comfort, allowing them to communicate and eat. There is permissive hypercapnia, a shift in ventilatory strategy away from trying to normalize blood gases, focusing instead on limiting dynamic hyperinflation, air trapping to prevent lung damage. Targeted oxygen therapy. Management of hypoxemia has moved to a controlled approach. Target SpO2 is 88 to 92% rather than high flow oxygen, which can worsen hypercapnia. Shift in drug management. Widespread adoption of dual bronchodilators, LAMA and LABA, as described by Professor Urpita Laha, over monotherapy, and precise guidelines for the use of inhaled corticosteroids based on blood eosinophil counts to prevent future exacerbations. And thank
Yes,
you.
please continue.
And high flow nasal oxygenation is increasingly used for COPD patients both in acute exacerbations and as long term home therapy, acting as a bridge between conventional oxygen and NIV. It helps by providing heated, humidified, and precise oxygen flows, which clears carbon dioxide from the upper airway and reducing the work of breathing and decreases respiratory rates and improves patient's comfort. Thank you, ma'am.
Thank you so much. What are you really using? Are you using HFNO on a routine basis and then shifting to in more invasive strategies, or you're still following the usual route?
Actually, we are using BiPAP or CPAP if possible, if the patient can tolerate that. If not, if we found in ABG, that is there is severe acidosis less than 7.2, pH is less than 7.2, then we'll opt for intubation.
Thank you. Thank you so much, madam. I know there are lots and lots of questions, but our time is limited. So my last question for this session will go to Professor Orpita Laha. Madam, why do you think there are so many extubation failures in these cases? And how would you really help us? What would you really advise us so that there are less extubations?
Extubation failure is defined as inability to sustain respiration after removal of endotracheal tube or tracheostomy tube and need for re-intubation within a specified period of 24 to 72 hours or within 7 days. Incidence of extubation failure in COPD cases are very high, ranging from 6 to 47%. Most causes are unresolved nosocomial pneumonia, then airway edema from prolonged intubating procedure, or inability to clean secretion, inability to generate cough, negative inspiratory force minus 19 to minus 25 centimeter of water, unable to generate, decreased level of consciousness due to prolonged effect of sedative and analgesic agents, or deconditioning, poor nutrition and deconditioned muscles, respiratory failure, hypoxia, hypercarbia, respiratory acidosis, heart failure, and neurological impairment. These are the main causes of extubation failure in COPD patients in ICU. And management is to continue this. If this patient cannot sustain respiration, has to be continued in ventilation and or NIV. And treatment of specific causes to be required, like antibiotics for nosocomial pneumonia, mucolytic and to remove excessive secretions, and improvement of nutrition for betterment of muscle weakness. Now, recently it has been diagnosed that prophylactic steroid by methylprednisolone 20 milligram in 4 divided doses, if we give 12 hours before extubation procedure, it reduces the incidence of laryngeal edema and rate of re-intubation. Thank you.
Thank you so much. I can see there are still no questions in the chat box. So we move on to our next session. And in parallel with recent changes in the patient management strategies, we have another revolution that has come up and is quietly transforming outcomes across surgery and critical care. That is patient blood management. Patient blood management challenges our conventional dogma. If hemoglobin is low, transfuse. I request Dr. Palash Kumar to moderate this session on patient blood management. Palash, please.
Good evening, everyone. Initially, let me thank the Scientific Academic Committee of RSSCP for allowing us to have this conversation. As rightly mentioned by Dr. Ghosh, we are actually seeing a change in how we transfuse. If I can put it in a small, just a few words, from being reactive to blood loss and acting by blood loss to be replaced by blood, we are moving to a more proactive scenario. Because patient blood management is no longer a theoretical concept. The last decade or so, we have established it in a well-grounded manner. The evidence is quite strong. It sits at the intersection of science, patient safety, and our day-to-day clinical reality. So today we're going to keep our discussion grounded in the real-world practice, keeping away from the guidelines. We'll try to explore why, in spite of knowing that there is a significant evidence that suggests we can improve patient outcome by reducing transfusion, what are the limitations that we face, and how can we actually reduce the use of a commodity which is very precious and rare, that is blood. So today we have with us two very experienced clinicians and teachers, Professor Moitri Mukherjee from Malda Medical College and Professor Sujata Ghosh, both of them heading their respective anesthesiology departments. Professor Ghosh is from the Rampurhat Medical College. So let us try to understand what are the problem areas that they face and how they navigate their scenarios. So let me begin by asking my first question to Professor Mukherjee. I will ask this question to both of you, in fact. So when is actually you first get to meet your patients? Depending upon the scenario of your clinical practice, I know this can vary widely. So I would like to know, since you work in a high volume government setup, what is usually the first time the patient comes to you before meeting an elective surgery? And how many of those patients you feel, I guess that they suffer from anemia? I think.
Dr. Moitri?
Okay, I think.
In the meantime, I will start answering this question. By the time Moitri is comfortable, I think she has some lag somewhere, technical lag. Anyway, I would really start answering your question by saying how I wish I got these patients 2 to 4 weeks earlier. But well, it is usually that we get our patients barely one, very happy if we get 7 days earlier. And often enough, if it is an emergency case, I get my patient just an hour before surgery, often, very often. Not only in trauma patients, which is obvious, but you see, my hospital, and which is also the scene in many parts in India, many of my patients come from Jharkhand, interiors of the forests, and very remote villages, which has very poor accessibility through roads. So when they actually come, it is already too late for a lot of rehabilitation, optimization. These are words that is applicable to some of my patients, and for the others, I'm sorry, I really do not get the time.
Okay, Maitri, so
am I audible now?
Yes, yes.
Yes, you're audible.
So how soon, or rather how late, do you actually get to meet your elective patients? Because as far as emergency patients are concerned, we can't really, like have these discussions regarding what we'll do with them because of their already present anemia. So what is the best case scenario for you? And I know most of the time it's not very good.
Yes, my experience is almost similar like Dr. Sujata Ghosh. Like I'm working in a peripheral medical college, and often the patients are referred for pre-anesthesia checkup 1 week before. So there is anemia, and the cases of less hemoglobin is more in cases of orthopedic and trauma cases, which are mostly referred 1 week before, when we have got very little time to follow those less like restrictive strategy of transfusion. We have very less scope. But when I used to work in a Kolkata based medical college, then we used to get the patient around 4 weeks to 8 weeks before in pre-anesthesia clinics. Then we have little chance of optimization of the hemoglobin before putting the patient to the operation. So the experience in two setup, like peripheral medical college and city-based medical college, is somewhat different. Like in peripheral medical college, we are getting just 1 week before or 2 days or 3 days before we are getting the patient for pre-anesthesia checkup.
So in a more urban setup, we do have a slightly more headway. I work in a private setup, and I do get a few of my patients get to see about 4 to 6 weeks back. So it also varies a lot from the surgeon to surgeon, because as you are practicing anesthesiologists, you understand that unless the surgeon sends the patient primarily to us, so that is somewhere we have a little bottleneck. So just few briefly before we getting into the main discussion. So just that when we talk about patient blood management, we are basically talking about three pillars. It's said that there are three pillars. So one is optimization of the preoperative hemoglobin. And from your statements that we rarely do not get that much of a time, maybe 7 days, 10 days. And very rarely, if you're in an urban setup, you might get about a month or so. So one is optimization of preoperative hemoglobin. Then the part two is, of course, how can I minimize blood loss and minimize transfusion? And
Right.
then how we can sort of change the patient's tolerance to the anemia, and how can we make the patient tolerate anemia better, and so that our total transfusion as a whole becomes less. So Moitri, let me ask you again. So what is the sort of minimum set of investigations that you are happy with? I'm talking about really minimum set of investigations, and by investigations, I'm not meaning, do not want you to cover the whole gamut of preoperative preparation, but just the tests that anemia concerned regarding anemia.
Okay, Dr. Polash, the patients, the prevalence of anemia which are posted for elective surgery is almost 30 to 40%, and it is more in case of colorectal cancer and trauma surgery and urological surgeries. And among the causes of anemia, iron deficiency anemia is seated at the top. Like not only in India, not only in a peripheral and Bengal setup, it is all over world. It is the iron is in the number one. So if we are investigating the cause of anemia, we would like to have a detailed history first. The history of the patient, that whether the patient is losing extra amount of blood, or whether the patient is taking any chronic medication that is hampering the process of absorption of some key nutrient like B12 or something, or if there is any surgical history, so that long segment of gastrojejunal system has been resected and there is a problem of absorption of B12 or anything. So that will give us an idea, or that will point to the diagnosis, we won't have to test everything for that. Now the next case we can do that, we are doing complete blood count for every operation. So in complete blood count in peripheral blood smear, we would like to see whether whether hemoglobin is adequate or not, and then whether the picture is microcytic hypochromic anemia or macrocytic or megaloblastic anemia. Microcytic anemia would give us a chance to investigate in the path of iron deficiency, and whether the megaloblastic will have an idea of giving your B12 or folic acid deficiency. Sometimes there is neither microcytic or macrocytic, that may be due to some complex causes of anemia. Now, among the iron deficiency anemia, everybody likes to check, or the standard investigation is the serum ferritin level and the transferrin saturation level. Now, there is confusion regarding serum ferritin and transfusion saturation level because it can be altered in inflammatory condition. Like ferritin, if it is less than 30 microgram, points to absolute iron deficiency. But if the patients are having any chronic disease like chronic heart failure or chronic liver disease, then 100 is set as the cutoff value of ferritin. And same about the transferrin saturation, that is also altered in case of your inflammation. So in inflammatory situation, though in real practical world, we can only do the iron and ferritin due to cost constraint, or our laboratory are not equipped to test so much big things. So to rule out the chances of your inflammation, it is the reticulocyte hemoglobin content which is free of the effect of inflammation, and this will try to help us to detect about the level of iron deficiency, and to detect whether sometimes the anemia is due to anemia of chronic disease. The iron store is normal, but it is not being utilized, like anemia of chronic disease. So we'd like to know about the glomerular filtration rate. Definitely that will the history will point us to the suggestion of whether the patient is having any chronic kidney disease. We can do, or usually as part of your normal routine blood test before preoperative investigation, we can do the LFT along with the indirect bilirubin and your LDH level. It will point us, it will help us to diagnose about the hemolytic type of anemia. So these are the tests. These are the tests usually done routinely before pre-op investigation.
Sort of thing. Okay. So Dr. Moitre, it's very important, something that you pointed out initially, that we must take a good history of the patient. In our haste to go for investigations, we often forget that if we are good with eliciting a history, we can actually narrow down the number of investigations that we
Right,
get.
right,
And not only that, we can actually interpret the results of that investigation
right.
much better way. So if we have the basic investigations that points to us an iron deficiency anemia, we can treat as such. And maybe it's pretty complicated than that. Maybe we need to involve an hematologist. So are you doing any routine tests of coagulation? I would want you to be brief because it's a very big subject. So are you doing a routine test of coagulation? If not, then what situations, just a few brief pointers towards where you do like to get a coagulation test done before a surgery?
Routine coagulation test actually don't have any importance, though I should agree that as part of the patients do not come for us with investigation. They ask the surgeon for investigation, and they routinely do the PT, APDT, INR and these things. But the routine coagulation test has no as such value. The coagulation test should be done in patient who has a family history of bleeding disorder, or the patients who are taking any anticoagulant, like patient is on low molecular weight heparin, or patient is on your newer DOAC or your clopidogrel. So these patients, and the patient posted for a major surgery where there is expectation of huge amount of blood loss, only in those situations the coagulation test are indicated. Otherwise,
Okay.
coagulation test are not
Yeah,
indicated
so
routinely.
in practical purposes, most of them come, as you said, surgeons get a
Yes.
wide
Yes.
sort
Yeah.
of routine
Absolutely.
sort of thing.
They
But
just
other than
stick,
that,
they
maybe,
just stick the
yeah.
investigation and
So
patient do and comes.
in the ideal circumstances, unless it's a very big surgery with a potential for a lot of blood loss, or a documented history that points towards the possibility of a bleeding disorder, other than these situations, a routine coagulation test doesn't really add any value. Now, if we are fortunate enough to get a patient who is anemic and comes to you with, let's say, 1 month before and has anemia, and one of the things that is recommended nowadays is to use IV iron. It has got a lot of benefits other than the cost, and the preparations have also changed since we're a student. So which agents do you use and how exactly do you use it?
Yes,
Intravenous.
exactly. The patient comes 1 month before. We
Now,
have
let's assume the patient comes
Yes,
at
yes.
least 4 weeks
1 month
before.
or like 4 weeks or 8 weeks before,
Mhm.
we have the options of giving them iron supplementation. Though I want to point to a study done by Span and colleague. They have given a treatment bundle of erythropoietin, iron, vitamin B12, and folate 1 to 3 days before surgery in cardiac patient, and they have seen less blood transfusion for the next 7 days. So it is never too delay to start the therapy. The literature is suggesting that regarding IV iron preparation if there is iron deficiency and the patient comes within 1 month, then rather than oral iron, IV iron preparations are preferred, because the IV iron, the newer IV irons are safer. They are well tolerated, and they replete the iron stone more quicker than the oral iron, and the patient can forget the daily oral iron dosage, and the daily oral iron dosage also can stimulate the hepcidin level of the liver, which will impair again the erythrocytosis procedure. So the iron preparation which are in hand are ferrous fumarate, gluconate, sulfate, and ferrate, and the newer non-dextran formulation allow complete or near complete replacement of a single setting in 15 to 30 minutes, improved safety profile, better tolerability, efficacy, and effectiveness. Now, the preparation which are available are ferric carboxymaltose, ferric dairy isomaltose, iron dextran, iron sucrose, and ferric dairy isomaltose has two dosage. One is 10 milligram per ml, one is 50 milligram per ml. The 50 milligram per ml is FDA approved only for dialysis patient. Now, the iron dextran has lots and lots of side effect profile. Now, the newer preparation, as you said, the carboxymaltose or dairy isomaltose, they are better tolerated and have less side effects. So So these things are preferable, and as per local protocol, the carboxymaltose preparation is most preferred by the treating physician.
Yes, that's also my
But
experience.
nowadays, dairy isomaltose is gaining popularity also because
So,
of a better profile.
so one benefit is that you can give a lot of iron in a small period of time. So 1000 to 2000 milligram can be given in a span of about half an hour, and newer agents are reasonably safe. There can be a bit of a reaction, but they do not cause anaphylactic reactions, which were the cases of previous high molecular weight dextrans that sort of gave IV iron a bad name. Just one more question in the preoperative field. So if you get a thrombocytopenic patient, what is your usual approach? Like one specific thing that most of us note, that patients that we get usually have a low platelet count. Even my own platelet count never goes above 1.5 lakhs. So what usually your approach towards a patient with thrombocytopenia when you find it?
Yes, thrombocytopenia, often the experience is the in government hospital, definitely we get a patient without any symptoms and his platelet counts is to be 45,000, 50,000. We send them for a repeat test. Usually the repeat test, it's okay. But for the guideline purpose, it is for a major surgery, one like neurosurgery, 1 lakh is a cutoff value for platelet. And for the other surgery, 50,000 is regarded as a safe level for proceeding for the surgery. Like often we get patient with PIH patient whose platelet count is between 50,000 or 60,000, and sometimes we have a doubt whether to proceed with spinal anesthesia or not. Usually in those cases we proceed, like if it is more than 50,000, we proceed with operation. But in neurosurgery, when they are opening the brain or anything, 1 lakh is a cutoff value for thrombocyte, like platelet count. We like to transfuse platelet if the platelet count is, like in trauma patients, sometimes due to absorption coagulopathy, the platelet count is less, and before opening the brain, we'd like to have platelet transfusion to increase the platelet count to at least 1 lakh for neurosurgical patient.
Okay. So my experience also matches yours. Often a repeat count, especially a manual count, sort of
Right.
cures and lower platelet count. I don't know whether your experience varies the same. I have also found that slightly elevated INR also gets corrected with a repeat test. I don't know what exactly is the mechanism here, but it often happens like that. Next, I would like to ask Dr. Ghosh one question. So what the surgical and anesthetic techniques and steps that we can incorporate in our daily practice so that blood loss is reduced?
Yes, that is something that we already have been practicing since quite some time. First of all, let's talk about the surgery. If we talk about the surgery, then what is advised is we go for laparoscopic surgery, endoscopic surgery, wherever it is possible. And the use of electrocautery, wherever possible, is indicated. And regarding the anesthetic practices, besides rehabilitation, optimization of the patient, a proper pre-anesthetic checkup with extensive history taking and finding what is exactly wrong. Basically, you see, the shift has been that do not treat the number, treat the physiology. So all this has become very important. So exclusive to anesthetist practice, you can do hypotensive anesthesia following all the guidelines. Tranexamic acid, giving tranexamic acid has a lot of importance and is gaining further importance every day in all types of surgeries. And it has come in the guidelines too. Giving tranexamic acid has come in the guidelines of crash 2, trauma, PPH protocol. It has come because it has a definitive role there. And of course, what we've been taught from day one, maintaining normothermia. It helps in controlling blood loss to a lot extent.
Yes, hypothermia is really important. In government medical colleges, when I was a student, the air conditioning was virtually non-existent. But nowadays, most modern OTs have got very high performing laminar flow systems, and the OT really gets cold, and patients drop 1 to 2 degrees pretty easily. So keeping the patient above 36 actually takes a lot of planning from the very beginning, like warming up fluid and everything, covering the patient well, convection heating and all that. So that's a very, very important point that we must all need to remember. Now,
One thing, may I be permitted to
yeah,
just
sure, please.
add a few things? One thing is that just in keeping with the dictum now, don't treat the number, treat the physiology. So often enough, what you really can't do is depend upon the INR, APTT, and values there. And more often than not, I've talked to pathologists, and what they said, that calculating platelets in the counter is a little difficult. That is why we often get wrong values. So instead of depending on the platelet count, APTT, INR, what we can do in the perioperative period is depend upon TEC or ROTEM if we have it. If we don't have it, then it's fine. We'll have to depend on it. But if we are in a very advanced center and we have all those, then it is better to depend on those two.
Yes, I think the availability becomes
Very important.
an
Very
issue of this course. Okay, Dr. Moitre, coming back to you. Now, since we are just about talking about numbers and numbers guiding our decisions, so it's a question related to that. So what are your transfusion triggers that you are using? The numbers. And when you are not depending upon only the hemoglobin value as a transfusion triggers, are there any other things that in taking into consideration, other tests or other patient factors like comorbidities or whatever? All those factors, please give us an overview regarding your transfusion triggers.
Like we know that nowadays everyone is saying restrictive strategy of transfusion, be it crystalloids, be it blood transfusion. So for a normal healthy adult individual, the number of hemoglobin after which we'll like to transfuse is 7 gram. 7 gram per DL is the cutoff hemoglobin. It is established by various big studies which is conducted multinationally over many country, and such like that a study is strict study which has established that 7 gram per DL is a cutoff for healthy adult. But if the patient has acute coronary syndrome or any other comorbidities, they cannot tolerate, like where they cannot increase the heart rate to increase the oxygen delivered to the tissues, then we have to start transfusing when the hemoglobin is around 8 gram per DL. Otherwise, they will suffer from the symptoms of ischemia. Should I point to the other non-hemoglobin criteria for infusion?
Yes.
Transfusion?
Yes.
Okay.
Please.
So nowadays they are telling that there are other things like delivery of oxygen. We are concerned about the delivery of oxygen. So delivery of oxygen if we can measure, but that is a difficult thing to measure. So other thing we can do, if we have a central venous cannulation, then ScVO2 and SvO2, that is mixed venous oxygen saturation, we can detect, because both of that falls during your anemia and will point regardless of the hemoglobin value. Like in during intraoperative period, we cannot assess hemoglobin. Like sometimes we do not draw blood or anything. When we do ABG, then we can know. So from ScVO2 or SvO2 we can judge. And NIRS, that is non-invasive like
Infrared spectrometry.
infrared spectrum is a newer thing which can point towards your transfusion decision. But the newer things another thing is ECG, like the signs and symptoms of your ischemia, like myocardial instability or less oxygen supply to myocardium. But these newer things like NIRS and then your ECG, these are very low specificity and sensitivity. Maybe with larger studies we can establish these things more strongly. But nowadays we can depend on ScVO2, SvO2. these things on for decision of transfusion.
So one thing that is very clear from whatever you saying is that what used to be our initial sort of knee-jerk reaction, whenever we see some degree of bleeding, we rush in with a bag of blood. So that needs to stop. We actually need to maybe maintain normovolemia with crystalloids that maintains the circulation and oxygen delivery. And we now know with enough evidence that patients can actually tolerate quite a bit of anemia and still be good. And in some cases where there are complications, we need to judge each case individually, and then depending upon the comorbidities that the patient has that influences their tolerance to oxygen delivery, we will of course modify our approach. So individualized approach in all cases is good, and we must
Right,
the
right.
tolerance of the patient's anemia. Dr. Ghosh, so this is all something that we can practice. Most of it we can practice in our daily life, but there are few things in patient blood management domain that may sometimes makes it a little unpopular, is slightly tech heavy stuff like cell salvage and acute normovolemic hemodilution. So these are things which are talked quite commonly in this when we are talking about blood management. So what's your impression, idea, if you have any experience about these things? Unmute yourself, please.
Honestly speaking, in the hospitals that I have worked, we did not have the gadgets for self salvage. So what I will be explaining is my take on it, my understanding of it. Basically, what used to be done before is pre-operative autologous donation. PAD has now become obsolete in all forms of patient blood management. What we heavily depend upon is cell salvage, intraoperative cell salvage. And the basic procedure is collection of the blood. But you must remember, if it is infected with fecal matter, if there is malignancy, then you cannot take that blood. Otherwise, if there is massive hemorrhage, during the surgery, you can collect the blood. After collecting the blood, you filter this blood through specified filters, and then you centrifuge it. Following centrifugation, you have to wash this. Why? Because you have to remove the clots, you have to remove the debris, you finally also remove the plasma, and what you take is the RBC, is the washed RBC. What do you wash with? With 0.9% normal saline. After this, it is given. The problem is that the initial setup costs quite a lot. But if you have it, it is a very good and useful gadget, especially in places where there is a high volume surgery, which entails a lot of blood loss. And one more thing about cell salvage is that there is occasional coagulopathy, because this transfusion of the cell salvaged material does not contain the coagulation factors. This is one very important thing. Now, coming to normovolemic hemodilution, I think many of us have already been practicing it. But it is very important to look into the physiology of the patient before practicing it. If the patient is already anemic, it's best not to go for it. You should stop at a certain point, right? But this is a very good approach, because what happens is when there is ongoing blood loss, a lot of blood is not lost. And after that, after clamping of all the arteries, all the blood loss secured, if you transfuse the RBC, it is better that the patient will have a higher oxygen carrying capacity with the transfusion, which is done later. But initially, how much will you lower? You should not lower it below a hemoglobin level of 7 gram%. This is roughly my take on acute normovolemic hemodilution.
Yes, cell
And
salvage is quite
cell
right and needs an initial investment, but acute
But once
normovolemic
you have it, it is
hemodilution,
very good.
acute or normovolemic hemodilution, as far as my idea goes, can work really well in a few cases, especially when we have a predictable intraoperative blood loss. Now,
Right, absolutely.
if the blood loss tends to have post-operatively, there are surgeries when there is quite a bit of blood loss in the post-operative period, like bilateral TKRs and all these things. But if we have a kind of a vascular mass, we anticipate predictable intraoperative
We
loss. In
usually
that
wait.
case,
We usually
in
wait.
these cases, I think this
Yes. After
particular
the mass
technique
is reduced,
can be adopted. We do not need additional equipment and all that. All we need is
no.
preparation. We
It's
need to
very
be prepared
easy.
from it. Okay, Dr. Maitri, so in the post-operative period, what can we do? Because this is one of the changes in blood management is that just after the surgery is over, we have transfused blood and shifted the patient out of the OT. This is not all where our responsibility ends. In patient blood management, our responsibility extends to returning the patient to a best quality of lifestyle in the post-operative period and possible. And what do you think can be our responsibilities that we can, or the things that we can do to help this in the post-op period?
So in post-operative period, we should target for optimization of oxygen and analgesia, both of which, if inadequate, increases the oxygen depth of the body, which is when the patient is already anemic. Now we have transfused, maybe in acute situation, we have transfused blood, but we have not repleted the iron store, which is already less inside the body. So we can think of iron supplementation in the post-operative period also, so that the body store is depleted and the erythrocytosis process is stimulated in post-operative period, because lots of studies in critical care and in post-op also shown that if the patient is sent anemic at the home, they take lots of time to recover from the weakness and recover from the stress of those things. And other things we can do, we can minimize phlebotomy, because in post-operative period, we are sending lots of investigations. So the number of phlebotomy we can decrease. And another important thing, if the patient needs thromboprophylaxis, that should be balanced with the risk of bleeding. So these things we can do. And what, like every other things we are doing, like we are oxygenating, we are giving analgesic, like phlebotomy part we cannot influence that much, and thromboprophylaxis, everything we are given, but we are forgetting about the IV iron preparation, which can be given in the post-operative period also, that we should consider in the post-operative period.
Okay, so these are nice points. I think most of us can incorporate these things in our practice. So just to end our discussion, and these are all nice points, but how do we start to win? I mean, I am certain that we are incorporating quite a number of these things in our daily practice. Apart from probably targeting a hemoglobin before surgery, that is where we are mostly limited by our access to the patient before surgery. I would like to have one concrete step that you would like all of us to go back from here and start doing from tomorrow that can help us in achieving this goal of minimizing transfusion. Dr. Moitri?
If we are lucky enough to get the patient 4 to 8 weeks before the surgery, along with other things like iron supplementation and everything, I would like to counsel the patient regarding the dietary habit, because the dietary habit influence lots of nutrient and micronutrient absorption. Like the vegetarian, they are lacking vitamin B12. So the dietary habits needs to be formulated. Then smoking cessation, because the smoking is, like, we are concerned about the hemoglobin, and ultimately our concern is oxygen supply to the tissue. So cessation of smoking, cessation of alcohol intake, because the chronic alcoholic, they are, like, again, their vitamin B12 absorption is being hampered. So this counseling we can do. And there is one term, that is shared decision making. Like the patient can choose that what they want to do, like what are the options, what are the risks, And what if they choose nothing? Like some of the patient, they can just refuse that we don't want blood transfusion. Then we have to plan accordingly, like acute normopolemic hemodilution or iron supplementation. Like we have plan like that. And if the patients are willing and we have time, definitely we have talked about lots of iron preparation and everything, because iron, when once given, start to improve the hemoglobin level within 4 weeks and start to replete the iron capacity of the body. Even if the patient's hemoglobin is normal, like I came across a patient few days before that hemoglobin is normal, but ferritin level is around 25. So this patient definitely will benefit from iron supplementation. Maybe they are not having less hemoglobin at this point, but their hemoglobin is going to decrease in the course of 4 weeks or 8 weeks. So these things we can do, that counseling of the patient and iron supplementation and another thing I forget, very important thing, that optimization of the oxygen delivery, like some kind of exercises are also promoted so that the delivery of oxygen to the tissues are improved. So the tolerance of the anemia is improved in the perioperative period. So these things we can do. And definitely if we have a chance in our pre-anesthetic clinic, like in peripheral setup, it is a dream. But if possible, there should be a point of care hemoglobin test. Like when the patient is coming, we are taking the hemoglobin level.
As
Or
soon as
sometimes
possible.
the patient
Yeah.
in the preoperative period are posted for some renal scan, and urea creatinine is necessary for that if they are giving dye. At that time, we are taking a
Okay, I think
hemoglobin level. And the hemoglobin, if it is less, we are just trying to improve the hemoglobin level. These things we can do,
okay. I
incorporate
will
in our
move
practice.
to Dr. Ghosh.
Uh,
Some concrete suggestions that we can start immediately.
Honestly, I would go for a multidisciplinary approach. On one side, I will request my surgeons to send the patient as early as possible. And on the other side, I would ask all my postgraduates to take the history carefully, to delve deep into the history. Regarding the patient shared responsibility, this is one of the shifts of the recent blood management, patient blood management system. But besides that, intraoperatively, I would go for surgical steps to reduce blood loss, adopt anesthetic measures, which I've already said, tranexamic acid, hypotensive anesthesia, normothermia. And along with this, I would also start an anemia clinic, just like Dr. Moitri has suggested. Anemia clinic is coming up in a big way in most of the institutions. This will really help me in the long run. And I would also ask my authority to invest in self-salvage products, machines. This is all I can do from my end. Besides that, all that have been discussed today is in brief that we are already trying our best to do and will be doing in future.
Okay, so just to sum up this discussion,
So I would also like your take, Dr. Polash, on this.
yeah, I think we are doing quite a number of these things.
Correctly.
We often get stuck in the technicalities of it and often do not see all of it together. So it's not a technical thing. In my personal take, that this is mostly about a mindset. I mean, if the patient loses a blood, we first have to ask that, can we manage without a transfusion? So
right, we should not overorder.
That's we should not overorder, and that's I think need some systematic changes as well. How late I can order a unit of blood. There are some institutes which have these kinds of protocols where they minimize the amount of blood that a surgical unit can actually requisition. So that sort of curtails their enthusiasm of using blood and blood products.
Right.
And at the end of the day, we have to respect the fact that blood is a very precious commodity and we must use it as judiciously as possible, because evidence is quite clear. If we can reduce transfusion, the outcomes do improve. So
Absolutely.
there is no way. And one thing that has my practice has changed, one specific attitude, that when a patient loses a lot of blood suddenly, previously I used to rush in with the blood, but now I mostly play with crystalloids and a small degree of inotrope to keep the circulation flowing. And as late as possible, I would tend to start the transfusion, keep the transfusion to
Dilution
minimum. Okay, I think there are a few comments
questions there.
in the chat box.
Some comments and some questions.
Yes.
Could you please take them up?
Yeah. So, Dr. Shoikot Negi will go back to the first discussion is COPD management in critical care unit and the perioperative period. I think a few part of it regarding the important changes that we are seeing in the critical care management have already been discussed. So maybe we can add 1 or 2 points regarding managing a COPD patient in the perioperative period. Dr. Laha, Dr. Nyogi.
Hello. Am I audible?
Yes.
Yes, you are.
Yes. COPD management in perioperative and ICU setting, it mainly concern optimizing the lung function and preventing bronchospasm. As Dr. Urpita Laha already described regarding the medical management, it is very important. And few things for operative patients, we stop smoking. If the patient is a chronic smoker, we will try to stop smoking for at least 4 to 6 weeks before surgery, elective surgery, and proper smoking cessation, bronchodilation, and corticosteroids. This is the key strategies include regional anesthesia and minimize mechanical ventilation time and early mobilization. All these prevent post-operative pulmonary complications.
Okay,
And
then we have a question from Dr. Singla. He asks, can we wean a patient on an FiO2 of 0.6? And what is the minimum PEEP that is acceptable for trial?
0.67, if FiO2 is really high for weaning, we will allow 0.4 to 0.5, that is 40% to 50% FiO2. If the FiO2 is very high, there is chance of extubation failure and there is possibility of re-intubation. And regarding PEEP, it is less than 8. Preferably 5 to 8 is suitable for weaning. If we use too high PEEP, then there is chance of extubation failure and chance of re-intubation is more.
Regarding FiO2 60%, one thing is that if other things are normal, for the disease process, the patient was being put on ventilator. If it has been reversed, or hemodynamically patient is stable, or maintaining saturation, or PaO2 is more than 60 millimeter of mercury, in that cases, we can try to go for trial if FiO2 is more than 60% also. It is not the absolute contraindication for weaning. The main thing is PaO to FiO2 ratio is important, and PaO to FiO2 ratio is more than 300 is acceptable for weaning.
So basically what you are suggesting is that we have to check that the diffusion is more or less working. I mean, it's not severely impaired, and if that is so, you have to be more circumspect. Now, he has one more question regarding this extubation. He's saying that is vasopressor support an absolute contraindication for an winning trial?
The vasopressor support is not absolute contraindication. A minimum dose of noradrenaline can be, jolly oil can be used for weaning purposes. If the main thing is patient is MAC more than 60 millimeter of mercury and saturation is more than 99, more 80 to 95%, and PO2 is more than 60 millimeter of mercury. In that cases, if patient is maintaining over that, then we can go for trial, keeping vasopressor on in minimum dose.
Okay, next question is, what are the blood stats from where iron preparations can be started? Maitri? Microphone. Unmute yourself.
Yes, regarding blood statistics, is a ferritin level which is seen before starting iron supplementation. Like I tell that if the hemoglobin is also normal, but the ferritin is low, we can think of iron supplementation because the body store is less. We need to the body store of iron is a huge body store is there, and the body is utilizing the shed of erythrocytes to make the hemoglobin normal, but the hemoglobin is going to decrease when the ferritin is already low. So ferritin usually is a thing which still dictate us for regarding transfusion of iron, though it
If we
has.
let us assume that we do not have ferritin and we just have a blood count, and is there some
If
hemoglobin
it is
value where you would like to start a ferritin, I mean, start an IV iron?
uh, by only seeing hemoglobin level, yes, if it is the absolute hemoglobin level, as who has given the criteria of anemia, it says 13 for male, 12 for female, and 11 for pregnant women. So considering that all the women population in India, they are anemic. So if the absolute hemoglobin count is less than 10, we can start the iron supplementation. And especially if the picture is microcytic hypochromic, that is the most common picture we found in the
That
blood
tells us that
nowadays.
it's most likely an iron deficiency anemia.
Yes, yes.
Government
about
of
the
India
IV
has
preparations, ma'am?
already, Dr. Polash, Government of India has already started IV iron, giving IV iron in pregnant mothers, anybody below 9,
Right.
right?
I think
It has become a routine protocol now.
if we are in the pre-operative period, I think we can be a bit more liberal about
Comfortable.
giving iron because the
Yeah.
patient is going to lose blood, so we can start at a higher level. So there are a few guidelines which suggest that even at 12, if we are going for a surgery when there is going to be a lot of blood loss, even at 12 hemoglobin, we can start. That will help the patient to
Right.
maintain the hemoglobin store and mount an appropriate hemopoietic response when he or she loses that blood. So maybe
Right,
some
right.
degree of individualization can be there. I think the greatest advantage is to circumvent the unreliability and the side effects of oral iron, whereas oral iron is not a very pleasant medication, or nor is it very efficacious.
Also,
So
sir, I would
One
like
thing,
to add on that the compliance for oral preparations is very poor in India.
actually, there is a lot of gastritis involved. So
Yes,
that
ma'am.
is one of the reasons for poor preparation
yeah,
and
one
black color of the
Also
stool.
also the oral iron increase the level of hepcidin. Hepcidin is a marker for your iron absorption of the body. If the hepcidin level is high, how much iron you supply, that will not be utilized in
yes,
erythrocytosis process.
that's
So if
exactly
we
right.
talk only in the terms of hemoglobin, ma'am, then what is the blood stat levels for IV preparations, ma'am? Or do we have different parameters for this, ma'am?
Sir, actually, for carboxymaltose, the best part is that it is a single dose,
Yes, ma'am.
right? It is
Yes,
either they give either 500 to 1000 or 1000 to 1500, depending upon the hemoglobin level.
Is it
So,
more than 1000 is advisable, ma'am, in pregnant women?
not in pregnant, sir. Not in,
Not in
in
pregnant.
pregnant, it is 1000.
Maximum 1 gram is advisable.
Yes, yes. 1 gram. So, but one thing is that there are also side effects of oral iron, and if it is non-compatible, it is best to give IV iron, whether
Actually,
it is pregnant or non-pregnant.
I was reading a advisory by the NHS a few days back. So they are saying that oral iron, even one dose reduces the absorption of iron quite significantly for the next few days. So they are suggesting that give oral iron for only 2 days a week, and that's almost as efficacious as giving daily iron, because the absorption falls dramatically with daily dosage. I do not have detailed information of this, but this sort of supports this theory that iron increases hepcidin, and it extra iron is very toxic for the body. So the human body is very efficient in maintaining only the small amount of iron absorption of it.
And
So-
one thing you must remember that India has a lot of thalassemia and HBE
Yes,
trait,
that's very important.
and that will be really dangerous.
Yes.
Maybe we have to be more proactive in
Yes,
picking out those
nowadays
cases of
HPLC is
thalassemia and
already,
do not give
HPLC
them
is
IV
coming
iron,
from-
which can be really detrimental.
Like for pregnant mothers, HPLC has become a routine investigation
Investigation.
because of this reason.
Okay. Professor Dipashree Bhattacharya madam had made a comment that
Yes,
you have to
yes.
exclude ITP. That's very, very important. And history is very
Very-
important in thrombocytopenia patients, and in ITP, platelet therapy has no role. Matrey?
Yes, rightly. As the when we have read about the indication of platelet transfusion, I've read about the contraindication of platelet transfusion as idiopathic thrombocytopenic purpura. But as I said before, investigating the anemia, we'll like to have a detailed history of the patient along with physical examination. Now, these ITP patients will have the history of petechial hemorrhages and then easy fatigability, and on examination often they will have splenomegaly, and if this findings is associated with low platelet count, that will point to our idiopathic thrombocytopenic purpura and all other like platelet antibody test, and any specific test if needed we can do, or we can refer the patient to hematologist for steroid therapy on everything. Like from history, we can have an idea that it is the low platelet count is due to idiopathic thrombocytopenia or not.
So history again proves to be very, very important. This is a lesson for postgraduates that history, taking a very good history, the importance of it cannot be overemphasized. Otherwise, you will miss all those things. Dr. Shoykot Neogi mentions that blood management is more difficult in acute situation. What about that? This is a very true scenario. In fact,
Yes.
all the discussion we have about improving hemoglobin is simply not applicable if we have an acute scenario. So you have to take only the intraoperative and the postoperative factors that we have discussed into this account, because preoperative optimization is not going to be useful. Dipashree Bhattacharya ma'am has also mentioned one important thing, that chest physiotherapy is important in the COPD preparation.
True.
Dr. Neogi, would like to make a comment on this? Chest physiotherapy
Yes, it is very much
in
helpful.
preparing an importance.
It is very helpful, and it is included in prehabilitation. It improves the breathlessness, it increases the strength of respiratory muscles, and sputum clearance is also improved by chest physiotherapy.
Right. IV and oral iron preparation in pregnant, I think we have discussed
I
this.
think we've discussed it.
And Dr. Shoykot Neogi is making a point that hypotensive anesthesia cannot be administered in brain and spinal cord surgery and trauma surgery. Hypotensive surgery is a double-edged sword.
Yes.
To
Yes.
be-
And I completely agree. I agree.
It needs to be
And
judiciously used.
we'll have to carry out the other aspects.
It cannot be used in all cases. I think
No.
that's all we have in the chat box as of now.
I think there is something new that has.
Orpita says prehabilitation of COPD. I think we have discussed the prehabilitation part. Just one or 2 points, ma'am. Could you, if you just one or two of the most important points in rehabilitation in COPD patients?
Actually, prehabilitation with triple therapy is very important. It reduces the dyspnea, it reduces the easy fatigability of the patient, and it improves the exercise tolerance. And post-operatively, intraoperative and post-operative period may be uneventful with this. And we can also reduce the chance of post-operative complications with prehabilitation. And we improve the nutrition part and psychological part also with rehabilitation.
Okay, I think Dr. Urpita, this answers his question. So I think it's time we conclude this two excellent panel discussions.
Ma'am, I want to ask a question to Dr. Laha madam, Dr. Arpita Laha madam, please.
Okay, sure.
Ma'am, does a patient need to be fully awake for the spontaneous breathing trial?
Spontaneous breathing trial, sedation we will reduce the sedation level, and the patient will respond to the comments, and not fully awake is not required, but little bit sedation will be continued, but patient will be responsive only. He will respond to the comments, he or she. That is that we follow here in the ICCU. Not fully awake.
Right. Thank you very much, ma'am.
Thank you. I think we come to the end of today's discussion, and thank you everybody for staying with us till the end. Thank you so much. And sir, will we give the vote of thanks now? But before that, I would request Dr. Naveen Malhotra, sir.
No, please propose vote of thanks. I was just planning to congratulate
No,
all of
sir.
you.
Sir,
I
just
listened
in a
everything.
nutshell
And
about how we can do better, what more can we do, and what is your take on these two topics?
Actually, to be honest, I like the type of presentation that it was a sort of a panel discussion thing. So this is really appreciable, and I congratulate all the panelists, speakers, and good moderation by you. Heartiest congratulations. Over to
Thank
you.
you, sir. Thank you. I request Dr. Palash Kumar to give the vote of thanks.
Thank you, Ghosh. Respected President of RSSCP, Secretary RSSCP, other senior figures, Dr. Tej Kaul, Dr. Dipashri Bhattacharya, Dr. Parul Jindal ma'am, Dr. Tanvi, Dr. Sibla, and others. And on behalf of the RSSCP West Bengal, it's my privilege to deliver the vote of thanks. I extend our heartfelt gratitude to Dr. Naveen Malhotra for giving us this opportunity, and also Dr. Vishal Singla, Secretary RSA. And they have been consistent in their encouragement to us. And as at the beginning, Dr. Malhotra reminded us of our wonderful days in holding the RSSCP conference. So they have always been very encouraging and helpful for us, and always have pushed us forward to do things. And also a word of appreciation for the speakers and panelists, Professor Urpita Laha and Professor Mushumi Neogi. Thank you for your insightful discussion on the evolving landscape of COPD and taking these patients not only through the preoperative period, but intraoperative period, but also a very crucial period of the postoperative ICU care. And your clarity and your thoughts, clinical depth gives us excellent takeaways for us that we can use in our day-to-day practice. Also, a sincere thanks to Professor Maitri Mukherjee and Professor Sujata Ghosh for engaging in a very thought-provoking discussion, incorporating our everyday day-to-day practice clinical scenarios, and also giving us with a advice with a blend of evidence and bedside techniques and other useful tidbits that we can use in our day-to-day practice to improve patient outcome. Also, I would like to thank the RSA Academic Committee for giving us this opportunity and giving this excellent sequence of webinars that we keep seeing from time to time. It enriches us and encourages us to strive further. Most importantly, a heartfelt thank to all of you participants who have stayed with us all through this discussion. And without you, none of this effort is of any use. So this is your participation that encourages us and helps us to keep going. And we conclude today's webinar. Once again, we look forward to seeing all of you again in the next episode of RSSCP webinar. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank
Thank
you.
you.
Long live
Thank
RSA.
you.
Long
Good night.
live.
Long live RSA.
Good night.
Long live RSA. Long live
Long
RSA.
live RSA.
Long live RSA.
Long live RSA, sir. Good night, sir.
Good night.
Good night.
Good night.